in this day and age, there aren't too many general orthopedists left. So people really subspecialize. You have people that do shoulders that only do like rotator cuff work. You have people that do shoulders that do shoulder replacements. You have people that do, necks, people that do backs, people that do hand stuff just from the elbow down. So we are kind of super subspecialized in a lot of ways now. And I think that's good for the patients too, right? I mean, it's, you want to be a master. You don't want to be a jack of all trades master of none. You really want to be a master of your craft and do what you're good at and do well.
A safe haven for innovators to go off the rails. Welcome back to the Off the Rails podcast, a show about the runaway train that is our healthcare system and the innovators working to derail it. This is your host, Sydney Haytoff, and today we're joined by Good Bones, musculoskeletal, ortho extraordinaire, Dr. Benjamin Schwartz. How you doing, Doc?
I'm well. How are you? Thanks for having me.
I'm doing well, thanks. I am excited to have you on for a number of reasons. We've gotten to know each other over the course of the past year plus as Mishi has gotten onto the scene. You are now part of our clinical advisory board, helping us to iron out and implement effective evidence-based treatment pathways for ortho and musculoskeletal care. I'm also proud to have you as an angel investor on our cap table and happy to have you as a guest. I'd like to start with my standard set of questions. I'll do a little background on you first. My questions are going to be, where do you practice? What's your specialty and any subspecialty? What's your favorite food? And do you have any pets?
Okay. So yeah, I'll take those in order. So I practice in the greater Boston area, an area that's called the North Shore. So it's about 20 miles north of the city. Depending on traffic, it's either 20 minutes or an hour and 20 minutes to get into the city, but pretty much have everything we need up here. It's a good area. I'm an orthopedic surgeon and I subspecialize in hip and knee replacements. I did a fellowship in that. That's probably at this point in my career, 99% of what I do. Very rewarding specialty. You can see arthritis, cut out arthritis, cure arthritis. That's really why I went into it. Favorite food? That is a tough one. Probably go, good steak as my favorite food. Maybe a filet, nothing too heavy. A nice medium rare steak if I had to choose. And then I do have a pet. We have a 2.5-year-old golden retriever. Bailey is her name. Good dog, fairly well-behaved dog. And so it's the third child in the family.
Nice. Okay, very good. Let's dig in then. Let's start with the concept of or subject of joint replacements. I know that you just accepted a new role in your organization. Can you talk to us a little bit about that? I know I believe, centers around total joint vertical.
Yeah, so I accepted a role as the medical director for total joints for an ambulatory surgery center. So I've been doing outpatient joints and surgery centers for about 5 years now. This is a new surgery center that I'm joining. And, I'm all about figuring out new efficient ways to do things. I think outpatient joint replacements has really been, I don't want to say revolutionary, but I think it really is changing the landscape. Maybe it is revolutionary, changing the landscape of joint replacements. These are things when I started, 15 years ago in practice and 20 years ago as a resident, patients would come into the hospital. We wouldn't even get them up for a few days. They'd be in bed, they'd be lying around, they'd be in a CPM machine for their knee. Then they would go to rehab for a couple of weeks, whatever. And now we're getting them up the same day. I mean, I did 3 outpatient hip replacements today. And, by the time we're starting the third case, the first patient is out the door. And we know it's safe. It's not for everybody, but it is safe for a lot of patients. Patients really have taken to it. And, of course, it's cost effective. I think it's really started to change the thinking around joint replacements, which are, theoretically or historically, one of the more expensive treatments. We know the demand is going to be there. We know the costs are something we really have to pay attention to. I think the other exciting thing about it, too, is it allows me or any surgeon that has an ownership stake in a surgery center not only to benefit from doing the procedure, but also to benefit from the facility fee for the procedure. And that really gets people, pulling the right direction, more in tune to, how am I a good steward of healthcare resources, make sure that what I'm doing, the money I'm spending makes sense, is evidence-based. So I think that's really, it's just a win-win-win for just about everybody in the process, with the exception maybe of some hospitals and health systems that are expensive, but I think they're starting to understand that they have to embrace this in some way, shape, or form too.
And so 3 hips today, that's cool. How long does it take you usually on average
Yeah,
each
I
case?
don't pay attention to the clock. What I'm focused on is efficiency, right? So it takes me as long as it takes me. And I've been doing this long enough that, straightforward hip, probably hour and 10, hour and 20 minutes, skin to skin. And again, that's not, rushing, just taking my time, but you follow the steps, right? I'm somebody that's very step oriented. And so you follow the steps and it's reproducible. Every case is a little bit different, but as long as you follow the steps, then usually, you can kind of figure it out. But yeah, probably skin to skin, hour and 20 minutes.
That's wow. Okay. An hour for a total hip. I'm sure that comes as a surprise to some people. What would you say and look, like I say it comes as a surprise because you think about total joint replacement. That's something that, it's a life-changing procedure for
Yeah.
many people. And it just speaks to the efficiency and the tech advancement, if you will, that we've seen.
Yeah, I mean, I spent a year learning how to do this extra outside of my residency, and I think it wasn't like that when I first started my career. It took me a lot longer, and over time, you become more efficient. You cut out steps that don't really add anything to the procedure. Your instincts, your intuition, your experience takes over, and you can anticipate things, and then you kind of hone it down to a science. And like I said, I don't look at the clock. I'm not rushing. You can be good and fast. You can be bad and fast. You can be good and slow. You can be bad and slow. I think you want to be good. If you can be good and fast or good and efficient, I would say not fast, good and efficient, that's great. If you can be good and slower, that's fine too. You don't want to be fast and bad. And so, as long as you're getting good outcomes, as long as patients are doing well, I think efficiency is really the key.
And what percentage of cases would you say of your cases are done in an outpatient or ASC setting today as compared to, inpatient or in the large health systems?
Yeah, so outpatient in the surgery center in my practice is probably about 20%. We do some outpatient same day in the hospital as well. And that's slowly growing. Here in Massachusetts, there's a lot of different factors that go into it. There's some political factors. There's also the patient factors and making sure the patients are comfortable with that they have the resources at home, that they're healthy enough to do that. So, it's not for everybody, but it is becoming more and more commonplace. There's certainly other areas around the country where they're 80 to 90% outpatient at this point. And, we'll get there at some point, but it just takes time to do it right.
And I read somewhere recently that the largest growing segment of patients to receive total joint procedures under the age of 60. Have you seen that as well?
For sure. Yeah. I mean, I think everybody anticipates like the baby boomer population. So we're accounting for that needing total joints. But I think there is a second wave. And I talk about this all the time of kind of like this young patient epidemic of hip and knee arthritis. And, even as young as 40 and 50-year-olds, we see them coming in and it's bone on bone hip arthritis or it's bone on bone knee arthritis. And so I think there's this kind of second wave coming that we're not necessarily ready for in terms of the resources in the system. There's different reasons for that. Some of it is like year-round youth sports, and just kind of when you're young and growing, putting stress on your growth plates and your joints can cause some changes over time, lead to arthritis. Or if you injure yourself playing sports, you have a ligament injury, or you tear your labrum in your hip or something like that, that can lead to arthritis at a young age. Fortunately, the obesity epidemic is contributing to that as well. But there is certainly this kind of second wave of younger patients coming for hip and knee replacements.
So that's a really interesting point that I had not ever considered. I have a German Shepherd at home, and they tell you in the puppy stage to not run with the dogs, German Shepherds, until they're a year old. And, year in dog years, some people say it's 7, some people say it's like 12 that first year. But I don't want to compare humans to dogs, but I mean, it seems like the physiology there is the same. It's the same concept where you want to give the growth plates time to settle. I don't know if I'm saying this the right way, but that's a wild because it makes sense. It makes a lot of sense.
Yeah, this day and age, a lot of kids are playing year-round sports. They just go from one sport to the next. So with the hip, and this isn't quite written in stone, but what we think is with the hip, you have this growth plate, and if you particularly like hockey players, we have this thing called hockey hip. So you're skating, and if that growth plate on the ball part of the joint is bumping into the socket, over time that repetitive trauma causes like extra bone to form, and that alters the anatomy and mechanics of the joint. that can lead to arthritis at a young age. Female patients are at risk of hip dysplasia. So that means their hip socket is shallow. And so I see a lot of younger females who have subtle signs of hip dysplasia on their x-rays. I don't know if that's a genetic thing. I don't know if that's the way that, where babies are being delivered now or whatever, but there seems to be this epidemic, I would say epidemic, but this increase in arthritis in younger patients for these anatomical reasons.
And you're saying bone on bone, usually. Like in
Bone
these
on bone
instances.
or pretty close to it bad enough that it's like,
That's
what else are you
wild.
going to do? You can send them to physical therapy, give them anti-inflammatories, you can tell them to, do low impact exercise. That's the other thing too. I mean, even this older population that's getting arthritis, people want to be active. They don't want to get into their older years or even their younger years and have to give up, running or skiing or golf, or tennis, or pickleball is a big thing. So that's a challenge for us. The expectations have never been higher. And that's the funny thing too, when I look back on my career, like where we started and what we were doing when I was a resident and how long it took people to recover. And now you're doing this thing in a surgery center, the patient's walking out like 2 hours later. It's like, how do in my career, we've come so far, but the patients expect that, and it can be hard sometimes to, to meet those expectations because, hips generally do pretty well and go back to doing most of what they want to do. But a knee replacement, we're still not quite there yet in terms of what a knee replacement can do for some people.
And would you say that there is a differential in the recovery time depending on the site of service? So, inpatient versus ASC, are people back to activity faster with an ASC?
Not necessarily. I mean, they're definitely out of the hospital or the facility faster. They don't necessarily recover any faster. There's a little bit of selection bias there. If you're choosing a healthier, more active patient, in the surgery center, they're probably going to bounce back a little bit more quickly. But, not necessarily. But I do think there is a benefit, to getting patients up quickly. Yeah, that's pretty much been shown in the literature that these rapid recovery protocols are safe and effective. You avoid blood clots, you avoid swelling and stiffness. So we know that it's safe to get up and get moving, right away. And the sooner you get people up moving, the quicker they get out of the hospital and the better they do.
And for bone on bone or near bone on bone, is there any alternative treatment, any alternative modality aside from total joint replacement that you would recommend that would give patients the same level of future mobility and freedom that a new joint does?
Yeah, the short answer is at this point, no. There's nothing tried and true when it's bone on bone. To get back to that level and get that level of pain relief, it is surgery. The long answer is, I tell my patients, nobody needs a hip or knee replacement. So when somebody comes to me like, oh, so I need a hip or knee replacement, I'm like, no, nobody needs a hip or knee replacement. This is not, life-saving surgery, but it's quality of life surgery. So you do it when you can't tolerate it anymore, when you're limited, when you've done other things, they haven't worked. And for some people, that's right away. And for some people, it's like never and anywhere in between. And so I always say, here's the options. You can go through physical therapy, you get a cortisone shot, you can take anti-inflammatories, you alter, you change what you're doing. Those are the things that are kind of, tried and true and recommended. If they don't work, then you consider replacement. There are other things, gel injections, PRP injections, stem cell injections that have varying levels of evidence to them. And I try to go through that with the patient to say, it's out there. I'm not going to, pass judgment on it, but I'll tell you this is what the science says and you decide for yourself. I may or may not recommend it depending on the situation, but I think you just have to present the options and be honest about it and make a shared decision with the patient.
Yeah, and I like your point about sharing the options and making that shared decision, because at the end of the day, it should be a shared, mutual, aligned, congruent decision-making process, both with regards to the treatment that a patient's getting and what impact it will have on their life, activities of daily living and their lifestyle, but also their wallet and the care, the health plan that they might be accessing care through. I think obviously that's in the context of total joints and some of these value-based surgical bundle offerings that are out there, Carum, Transcarent, Mishi. The thought is we're able to drive a better cost, a cheaper price by bundling the total episode or the total procedure, the surgeon, the facility, the anesthesia, the implant, any pre or post-op services, better pricing and a better experience than one would get, outside of those programs. And it's interesting to dig into the numbers to get a sense for the difference. And from a cost perspective, what is a total joint going to cost a patient or a health plan when it's performed in an inpatient setting versus when it's performed in an ASC? What's it going to cost when it is, a bundled procedure that's managed by one of these third parties versus the patient kind of navigating the system themselves? What are the downstream implications of, treatment after a patient receives, care, and the care or the post-operative pathway isn't managed, in an intimate way? So yeah, I'll let you respond, but I just want to say, like, it's, we're in this stage where some of these newer offerings are being presented, and it's cool just to give people a lay of the land. But I really want to start to dig in on, what is the true benefit of working with one of those groups? And what is it from your perspective?
Yeah, I think from my perspective, look, there's enough to worry about. It's a big decision to have your hip or knee replaced. This is still major surgery as far as we've come, and it is life altering, and there is a recovery involved, and it's not, overnight recovery for most people. So you have enough to worry about for that. You don't want to worry on top of that. Am I going to a good facility? Is my surgeon good? Are there going to be hidden costs? Is this in network, out of network? Patients want transparency. They want good care. They want engagement. They want, some form of customer experience. And we don't do a great job of doing that sometimes, in traditional healthcare. Is kind of a spotty thing or an inconsistent thing. I think that's what people want. They want consistency. They want transparency. They don't want, hidden things, and they want engagement. They want that customer experience that everybody's looking for. I don't think it takes much because we're not great at doing that in a lot of cases. I think if you can deliver all those things, it takes away that fear and just lets them, focus on recovery from the surgery, and then all this other stuff that comes with it, is kind of on autopilot, or you don't have to worry about, but at the same time, you're getting engaged. I mean, if you're in and out of a surgery center in 3 hours and you've had your hip or your knee replaced, there's not a lot of opportunities to interact with that patient. And so, having those, what we call touches afterwards, where we check in with them, or at least they have a team that's coordinating everything beforehand, afterward, they're going to do better. They're going to be a lot more comfortable with what they're doing, as opposed to, you drive up to the surgery center, you're in and out, and then you're kind of left to your own devices. And then you have to worry if some, huge bill is going to show up from the surgery center because the anesthesiologist was out of network, or there wasn't a carve out for this, that, or the other thing. If you can take that away, then that's kind of done and settled. That's one less thing, or a lot fewer things to worry about.
So in short, more confidence through more engagement and more touch points. And
yeah, it's all the things that people don't like about the healthcare system right now: expense, lack of access, lack of transparency, lack of education. It's all those things that are the frustrations for patients. You have the ability to kind of address that patients really appreciate.
And would you say that, from your perspective as, the quarterback of the episode, if you will, what ability or what opportunity do you have to engage with patients, or to what level do you lean on, the care team to do so? Because from my perspective, coming from the practice management side of the world and specialty care, ortho, spine specifically, but ortho, that follow-up touch is right. You're right. Is what drives the optimal, better experience. And a lot of times it doesn't even need to be the doc. It's nice when it is, but it doesn't have to be to get that same value, or for the patient to get the same value.
Yeah, for sure. I mean, it starts, when they first reach out to your office, whether they're having surgery or not. It starts with their first interaction, collecting information, understanding that patient, making sure you have all the information about that patient. And then when they're in front of me, spending time in the office, if they decide, hey, I'm ready for surgery, then, you start to educate, you start to let them know what they can expect, the pros, the cons, the risks, the benefits. This is how things are going to happen. And then it's time to then, as they're booked for surgery, there's a whole process ahead of time. And that's really where I lean on my team to make sure the patient's ready for surgery, that their health is optimized, to make sure the insurance part of it's taken care of, to make sure they're getting all the information going into it, that they can prepare themselves, they can, get somebody to help them through the process, set their home up properly, all that stuff. We have a team of people to manage, to make sure the I's are dotted and T's are crossed, so I don't have to micromanage that process. Don't want to do. And then, around the time of surgery, I do my part. And then the team takes over after that. Of course, in the OR, there's a huge team too, and I couldn't do it without, anesthesiologist, the scrub tech, the circulator, the PA, the housemaid, as a whole team of people that make sure things go smoothly. And then afterwards, it's the recovery room nurse, the physical therapist that gets the patient up, and everybody, what we know, particularly if you do an outpatient joint replacements, is if any step in that process, somebody, falls off message or isn't consistent. Patients hate inconsistency. If they get a mixed message from one person to the next, it makes it look like you don't know what you're doing, or it creates, anxiety on the part of the patient. So everybody's got to be kind of aligned, and everybody's got to have the same messaging from start to finish. And then afterwards, you call the patient the next day. I'm a big fan of, tech platforms to do asynchronous messaging so that, you kind of set it up ahead of time. It doesn't create more work for people that are already overburdened in healthcare, but the patients really love having that connection, that text message, that call, whatever it is, that makes it feel like you're right there with them throughout the process.
Yeah, and I think that's where people are excited about AI coming into the fold and playing a role in keeping patients engaged and keeping that confidence level high through that constant engagement and kind of always on approach, even if it's not even if it's not a real person behind the screen and it's an automated chatbot. It's just nice to know that something's there.
Right. I think that's the beauty of what we're seeing, or the potential of the LLMs and the chatbots is, it can be personalized. What we do now in the hospital is the patients, one of the hospital systems is like 13 hospitals. We try to get everybody on the same page. So the patient gets this generic, post-op recovery sheet so it's got to fit everybody's protocols. We have multiple orthopedic surgeons across multiple hospitals. Guess what? People do things differently. And all of us, as surgeons, like to think that we have things that we do that may be a little bit better, a little bit different. And when you start to homogenize things, you lose some of that personalization. And you also lose kind of, if you're giving people generic, information, it's not that helpful. They end up calling the office anyway. The nice thing about chatbots is, and LLMs is, look, I could train it on like stuff that I do, that Dr. Schwartz does. So it's a chatbot that's specific to Dr. Schwartz, and it feels personalized because it is personalized. At the same time, it's good information. It's not just something that you maybe scraped from the internet that doesn't apply or whatever. So I think that's really the potential, is it can get pretty close to, talking to somebody in person if you train it with the right data specific to that doctor.
Agreed. Yeah, they're wild. Would you say that the level of engagement that exists or occurs after, postoperatively, does that dictate the reduction of complications? Like, is that a correlation where if there is a drop off in communication, that patients are more likely to, re-injure themselves or re-enter the care system, in a way that could have been preventable?
Yeah, I don't think there's any question about it. Just because if they can't get in contact with you, or you don't kind of catch something ahead of time and preemptively prevent a trip to the ER, patients can end up there. So one of the lessons that we learned in the bundled payment program through CMS is you hire a nurse navigator, and that person contacts the patients after surgery. And, there's been multiple times where we picked up somebody who, maybe needed to go to the hospital because they were having some medical complication, or, was getting ready to go to the hospital. It's like, no, don't go to the ER, don't go to your primary care doctor, come in, we'll take a look, this is normal. So definitely, I think that drives patient comfort level. It keeps people ER that don't necessarily need to be there, because that becomes this whole cascading thing. So yes, engagement and really starts beforehand. So setting expectations of what to expect and what's normal and what's not normal, but following through on that, I think for sure drives better outcomes, less ER visits, less complications.
Okay, so I want to take a turn, and I want to discuss was it bundled payment for costage of BPCI, or
care improvement. Yeah, bundled payment.
Thank you. Care improvement. Yeah. Thank you. And so I want to talk about that and your experience in that, because from my perspective, that was essentially the government's first foray, the industry's first foray into bundled surgical care, and paved the way for what we're seeing today from a commercial and employer sponsored perspective. But want to really quickly ask the question, and this might be a leading question, but given the concept of engagement, you talked about hiring the nurse navigator to keep patients engaged preoperatively, postoperatively. I am assuming that doesn't exist so much within the context of these massive hospital systems where there's less customization and it's more of a, and I don't want to overgeneralize, but seemingly from what I've been told, is more of a churn and burn approach, less personal. It is, or could one make the connection that care or receiving care in a big box system, could that be more risky than getting care in the independent environment?
I think it depends. I think it depends on the setup. Hospitals have their own form, PCI, which was CJR, Comprehensive Care for Joint Replacement, which was not mandatory, or was mandatory, not voluntary for some hospitals. And so there was some incentive there. And hospitals can also get dinged on readmissions for certain diagnoses through Medicare too. So they have some incentive, to kind of manage patients. But like I said, you get these big hospitals and health systems, they want to homogenize everything, and that can kind of lose some of the individuality of it. Because of that, I think, the frustrating thing sometimes is that you have these huge hospitals and health systems that are supposed to be integrated, but it's not as integrated as you think. So it's kind of hard to manage the patient or guide the patient through the journey. So somebody shows up in my office, they maybe need a joint replacement, but they're not ready medically. Maybe they need to stop smoking. Maybe they need better diabetes, blood sugar management. Maybe they need to lose weight, but we don't have great mechanisms. I can send them back to the PCP, but the PCP doesn't necessarily know what I'm looking for, or we don't know, how to get that patient from point A to point B. And so I think the integration part of it sometimes can be, frustrating. And then, the OR doesn't know, or the pre-op area, the pre-op process doesn't know, what's going on with the patient sometimes. So yeah, I think that's the challenge of some of these big box systems, is it's like I've written about before, ownership, like who really sits at the center of that, who's really guiding that process. And sometimes that's where we, kind of fall down and struggle to kind of guide that process from start to finish. And I think that's where there's an opportunity.
And from your experience with these government-sponsored initiatives, value-based care initiatives, what would you say, what's your take on those? Were they successful? I recall in the past discussion that you and I had mention of kind of a race to the bottom, almost, if you will, with regards to cost efficiency, and to the point where it doesn't make much sense to be involved in those programs. So I want to get at your sense for that.
Yeah, I think there's definitely pros and cons. There's things that we learn. So we've been in it for 3 years. We're dropping out this year. So I think that they were successful in making us consider the whole patient, making us consider, hey, let's get patients as healthy as possible. Let's modify, improve the things that we can. There's some things that we can't change, but there are things we can improve. We can help patients stop smoking. We can help patients get better control of their diabetes. Those things that can lead to complications that we have the ability to change, we were able to change. And those are some lessons that we learned. We learned that, the biggest cost driver for total joints was sending patients to rehab facilities after surgery. And guess what? When they go there, their risk of complications and readmissions are higher. So most patients are better off and safer at home. And that also saves money in the bundle as well. So we've learned those things. We learned how to see the whole patient better as orthopedic surgeons. We learn what things have value and what things don't have value. The challenge is, in these bundle payment situations, if the target price continues to shift lower and lower, and eventually you reach kind of maximum efficiency, you squeeze as much out of the system as you can, then you start to go from upside risk to downside risk, and then you start to lose money. You owe money back to the government. And that's why a lot of people have dropped out of these programs, is that the target keeps shifting lower and lower. There's not good mechanisms to risk stratify patients, so they kind of treat a healthy 65-year-old the same as they treat 85-year-old with multiple medical comorbidities. The argument is, well, it all averages out, but we know it's not necessarily the case that it always averages out, that each healthy patient is offset by a less healthy patient. So that's another challenge within the system, as well as is poor risk stratification. Some of my biggest losers in the program were things that I think were out of my control. Patient wanted to go back on their biologic for their rheumatoid arthritis. So they got 2 doses of it, that 90-day window at $7,000 a pop. It's $14,000 that comes out of the bundle for medication the patient normally takes. And I'm not going to deny them. That comes out of my pocket. I had a patient diagnosed with a tumor that had to have surgery on the tumor in the 90-day bundle that I got dinged for. And it doesn't seem fair to hold the surgeon responsible for sort of things that are not related to quality or the surgical episode themselves. So those are some of the shortcomings in the program.
That's surprising to hear the RA and
Yeah,
that
basically
other
anything
way.
in that program, any kind of medical treatment that, happens in that 90-day window comes out of the bundle. They don't really differentiate. Was it related to the surgery? Was it not related to the surgery? It's just the program was not that sophisticated, so those things can cost money in the bundle.
That's wow. Okay, that's surprising.
Yeah, I think
Um,
that's one thing that people that have set up commercial bundles have done well is have these carve out or say, look, you're only going to be responsible for surgical complications if it's something that happens medically. It's not doesn't necessarily come out of the bundle.
and you have warranties. They're offerings that cover the procedure, that cover the episode, and shield docs from the financial implications of any complications that arise. So if a patient slips and falls and re-tears or breaks the bone or messes with the implant, that's covered in that warranty period, usually 90 days. And so I've
Yeah, I
seen
mean,
some longer than 90 days.
yeah, when you want to drive good quality care, you don't want to let people off the hook for doing a bad job, but you also want to be reasonable about it. That goes back to collecting, being somewhat sophisticated about collecting, analyzing data, and kind of making sure that you're not punishing people for stuff that's out of their control, but also not letting bad care or suboptimal care slide.
What do you think, based on your experience with those government programs, what would you or what do you envision is the most optimal way for implementing similar type programs that consider, the whole patient and, are intended to drive a more pleasant experience, a more effective, cost effective, clinically effective experience? What are your thoughts there? I know you have quite a bit of opinions on this topic and you've laid them out fairly comprehensively in your blog. You want to give people just a quick sense of the blog and then dive in?
Yeah, my Substack. It's called, what is it called? Dead Dry Bones. So you can check that out. It's linked on my LinkedIn page or Google it. It's called Dead Dry Bones. I write about this stuff, which is of interest to me when I have time. So it's not regularly, but I've got a post I'm working on right now, so it'll be up maybe this weekend. That is also along those lines. But I think the expectation is that the current programs are going to be sunset. I think CMS has already come out and said that. But what we're going to see is something maybe around what we call condition specific. So it's not necessarily going to be tied to a surgical episode, but really diagnosis of like knee arthritis, hip arthritis, or back pain. And CMS has announced this Making Care Primary program. So I think they are kind of opening up management of this, not just to the surgeons, but if a primary care doctor wants to manage arthritis to a point, and then the surgical episode is going to be kind of nested within that. So whoever's managing that condition will control the bundle for the surgery. I think it's an interesting approach. They're going to start tying patient report outcome measures to reimbursement. So making sure the patient's satisfied, collecting those metrics on patient outcomes. And so that's going to incentivize people to engage patients. It's controversial, right? I mean, who's best to manage arthritis, hip pain, back pain? Is it the primary care doctor? Is it the specialist? Are you pitting those two against one another? Isn't it better if they kind of come together? Maybe they will. Maybe you can get everybody rowing in the same direction and benefiting from delivering high value care. So I think that's the goal. But whether we'll see who ends up managing kind of the conditions and controlling that.
Yeah, it's interesting, this shift towards condition specific treatment rather than focus on the particular treatment itself. Something that I discussed in an earlier episode with peripheral nerve surgeon Dr. Demetrio Aguila. We were talking, about this exact concept where we have a budget of care or a budget for care, and I'd love to see a world where the patient and the physician or the care team are able to choose what the best treatment or care pathway is based on that individual patient's preferences and that individual patient's context, clinical context and history. And it's nice and yeah, it's good to hear that the government is going to be kind of going down that road, because then we will start to see, I think we'll start to see different innovative alternative treatment modalities explored and tinkered with a little bit.
Yeah, I mean, it does open it up to innovation. So long as you're getting good outcomes and patients are satisfied with what you're doing, I think it opens up a lot of possibilities. To me, there's a possibility for, somebody who can do that well, who can kind of bridge the PCPs and the specialists is really going to do well in a situation like that. It's good for patients too. I think there's been too much focus on inappropriate, unnecessary care. Just, do what's right for the patient. If it's surgery, it's surgery. There shouldn't be this maniacal focus on successes. The patient didn't have a surgery. Well, maybe it is, maybe it isn't. If the patient would have benefited from the surgery, and you've kind of delayed that unnecessarily, then you really haven't accomplished, you haven't done what's best for the patient. That's not value-based care. We can't confuse value-based care with like, non-surgical care or, lower cost care. Value is doing the right thing for the patient, doing it in a cost-effective way, doing it in an evidence-based way. It's not, look, I got to prove my value proposition. So the only successful outcome here is if I avoid a surgery, because that may not be the best thing for the patient. In the long run, it may actually cost the system more money if that patient, goes through treatments that aren't effective, non-surgical treatments that aren't effective, and they end up in the ER because they're, in hip or knee or back pain or whatever. So I think we need to get away from this idea that the only way to win value-based care is to keep patients away from orthopedic surgeons, keep them away from surgery. You want to steer them to people who are doing the right things and doing it well. But, I think we have to kind of change the thinking around what value is.
And the financial mechanism, right? How do you reimburse value? What does that look like? I think we've seen a shift towards value-based care in the primary care space with, advanced primary care, direct primary care offerings that are essentially, subscription-based primary care offerings. I, for one, think that maybe subscription-based model works in primary care more than it does in the specialty care environment. And so I've been iterating on what are the ways that we can introduce somewhat of a similar program in the specialty care arena. And initially my thought was, let's look at it by condition. And once patients are enrolled in or diagnosed with a given condition, then you enroll them into, a specialty or disease management program, and you can reimburse or pay the care team, whether it be a network or whatever that looks like, some capitated or monthly rate for just access and for the patient to be able to access treatment. But I think what that gives a little bit of bias, or it doesn't allow for, well, no, it does give bias towards the condition. And so for specialists in that environment or in that context to get access to that payment, if you will, the patient has to have a particular diagnosis. And then so it incentivizes that diagnosis, even if it's not necessarily true. I'm not saying that happens all the time, but
Right.
maybe.
Is it some subscription model around MSK in general? Is it, some type of like subspecialty specific, like insurance carve out, like we're going to insure you, against hip or knee replacement, or, some kind of back procedure or back pain or something like that. You can start to try to get creative with it. I think you always want to maintain access. You don't want to create these programs that, limit access. And how do you do that? How do you make sure everybody has access to it, whether they're commercial insured, or it's through their employer, or whether it's through a government program, Medicare, Medicaid? Can you create something that is accessible to everybody? Not necessarily to the same level, but is accessible to everybody to some degree and not exclude anybody. So you can start to get creative, but I think you want to also be inclusive.
Yeah. Yeah. I just to kind of continue with that thought, I'm thinking, with these DPC centered, APC centered, self-funded plans, the primary care, they're getting, $50 to $100 per month per patient. And if we use that same type of methodology or apply that to the specialty care arena and maybe to different, specialists within that ecosystem, what does that look like, right? Because the thought is that you're probably not going to treat the patient or have as many touch points as for the patient or for that population as the primary care doc would. And so I think the management fee or the reimbursement would look slightly different, probably be less, but you also have the ability to manage a larger group of people than, an individual primary care doc does because of that lower frequency of, touch points. And so what I've been iterating on is like, okay, how do we get a better understanding for what average utilization looks like for any given population, and then enroll the the clinicians, physicians, surgeons, et cetera, enroll all the specialists into a similar type subscription plan that allows them to get paid for the population, get paid to cover the population, and not necessarily paid to provide the treatment. But anytime that a specialist is needed to step in and provide care, they do so. And it's almost like, I don't want to refer to it or compare it to like an employed type environment where you're getting your salary and you're not incentivized based on utilization, but it kind of is that. It's just done in a different way. You're getting salary it's not necessarily salary, it's a capitated rate, right? Based on a monthly capitated rate based on the number of patients that you're treating in a population. That's where I've landed thus far. I haven't dug into the numbers to see, the number of patients that would make sense and what the cost of the plan would look like in that regard. But having been, being someone that has crafted surgical bundles, implemented surgical bundles in the past, or in the recent past, it is still, that revenue model, that business model is still dependent on utilization to make sense. And so just trying to get past that, there's really only, a couple of options. And so I'm curious to hear your thoughts with regards to that.
Yeah, I think it's probably some form of capitation, but you really you need the data, right? You need to be able to collect it. You need to be able to kind of figure out, okay, what do we need? If you have a certain population, X number of them are going to need this orthopedic specialty services or whatever. And over time, you can kind of understand that. And you can get actuaries or whoever involved to kind of, figure out, okay, on an average year, this is how many people we need to send an orthopedic surgeon. And so we're going to have a subscription model for this population because we expect that, X number of dollars are going to be spent, X number of patients are going to need those services. The orthopedic surgeon, as long as it's, set up in a fair and equitable and collaborative way, I think people would be open to that, right? If you can sort of know ahead of time what your costs are going to be or your revenue is going to be, and you can better plan and budget and do things like that, I think that kind of, frees you up as an orthopedic surgeon and concentrate on what you're doing and not worry about, how many cases to do this month or this year, how many patients did I see or whatever. If you kind of know that, okay, this is what I'm going to get, with maybe some upside and downside risk, depending on how well you're doing in that, then that sort of, it's not an employee model, but it's a more predictable model so long as it's, fair. And then you can also drive value that way.
Yeah. Yeah. And look, like it keeps the physician at the forefront of clinical decision making when it's not that employed model. I feel like you get the benefits, financial benefits of that employed type model, but you get the clinical autonomy of private practice. But the biggest question is, how do you manage that, and how do you implement a system like that? I don't think that the tools really are there yet in the space to do so, and I think that's the rate limiting factor here.
Yeah, the tools aren't there. The mindset isn't there. It's tough to change the mindset, from a fee for service and kind of volume based environment. Not to say that everybody's necessarily motivated negatively or has sinister motivations around volume. Some people do, but that's just the way the system is, and that's kind of how you're hardwired, and that's kind of how you measure your practice from year to year. And can you change that thinking away from, well, it's just about, how many cases can I do, how many patients can I see, towards, what can I do that makes sense, that's evidence-based, and still you have financial security from that, or not ground and overhead, or still be able to, have a practice model that makes sense.
And with that said, what are your thoughts on helping remove bias from the treatment plan by splitting up the diagnosing specialist, like creating some distance between the diagnosing specialist surgeon and the treating specialist surgeon? So like the thought is that, and specifically around, unfortunately, orthopedic surgeons, sorry, Ben, but the convention is that, a hammer sees everything as a nail. And I thankfully have experienced that in certain contexts, but most of you surgeons do the right thing, which is awesome. But I do believe that there are ways to completely eliminate that bias, or at least that concern, by driving some I don't want to call it a wedge, but like making the person the physician who is dictating the treatment plan different from the physician who's actually rendering the care.
Yeah, I think there's some challenges there. I think in theory that makes some sense. You could probably get 100 orthopedic surgeons in a room and present a case, and you would have 100 different opinions. So sometimes one person's opinion doesn't match somebody else's opinion. There's a lot of gray areas. Not everything is black and white. As much as we want to practice and should practice evidence-based medicine, we also have to recognize that the evidence oftentimes is very gray, and somebody, could be relatively conservative and somebody could be relatively aggressive, and doesn't mean one is necessarily right and the other is necessarily wrong. So I think you have to have some mechanism to resolve sort of disagreements and treatment plans and what have you. I do think there's an opportunity. I think this is something that surgeons might be, open to say, look, there's this layer in between, it's a non-surgical MSK specialist. This is between the primary care doctor and the surgeon to say, you're going to kind of filter through this layer that can kind of bridge those two things and evaluate the patient, manage the patient to a certain point, and then say, okay, I think this person is somebody that would benefit from surgery. We followed evidence-based guidelines. Maybe we have some sort of algorithm that, makes sure we've done that and helps us determine that, maybe now's the time to see the surgeon. And then that patient gets passed on to the surgeon so that you're sort of, the patients that see the surgeon are patients that are highly likely to benefit from surgery. You just have to figure out a way to reward everybody, along the way in those steps, because, as surgeons, yeah, we want to operate, but we also have to, in order to make ends meet, certainly in private practice, you have to, not everybody that walks through the door is going to need surgery. In order to cover your overhead, you also have to, be able to manage patients non-surgically and see patients in the office. A lot of them aren't going to need surgery. So if you can figure out a way to, incentivize that process and make sure everybody can focus on what they do best, but still, make ends meet and cover costs, then yeah, I think there's the potential for that.
And do you see a world where we get so good at risk stratification that doctors, surgeons, specialists start to hyper specialize, where you have a surgeon who is the best in their region at total joints, and there you guys are only doing total joints, and you don't really have interaction with the patient throughout the care journey until they get to your piece of the journey. You do, you knock it out of the park for them, but don't really have any input or exposure into what happened before, other than just reviewing clinical documentation to prepare for the case. Do you think that that's at all appropriate, or that there's any room for that in the future? I'm just riffing here. That's something that I've thought about and just want to get your thoughts.
Yeah, I mean, I think you always want to establish a relationship with that patient. So I think it's not one of those things where you just have a clinic as a surgeon where everybody walks through needs surgery and just spend all day booking surgeries. I mean, you do want to establish that relationship with that patient, get to know them, and that may be surgery right away, maybe it's a decision for surgery later. But I think for most surgeons, they do like to operate, and if they could pare down their clinical practice to what their specialty, their subspecialty is, what they're really interested in. Most surgeons, if they could, get away with that, would do that. I mean, I was joking today, I did 3 hips, they were all right hips. I'm like, now I'm a super subspecialist, I only do right hips. But most of us are pretty subspecialized. I like I said, 99% of what I do is hip and knee replacements. I take some call, I do some hip fractures. In this day and age, there aren't too many general orthopedists left. So people really subspecialize. You have people that do shoulders that only do like rotator cuff work. You have people that do shoulders that do shoulder replacements. You have people that do necks, people that do backs, people that do hand stuff just from the elbow down. So we are kind of super subspecialized in a lot of ways now. And I think that's good for the patients too, right? I mean, it's, you want to be a master. You don't want to be a jack of all trades, master of none. You really want to be a master of your craft and do what you're good at and do well.
And do you see that playing out at all in any way on the patient side? So similar to how, the supply side of healthcare, let's call it, sorry to, make it so impersonal, but the supply side of healthcare has gotten super specialized and hyper-focused. Do you see any future where we're able to do that on the demand side of care and group patients based on, lifestyle or type of activity that they, like to do? I realize that adds some bit of adverse selection and bias to the underwriting process with regards to, the cost of insurance and care in general. But I do believe that there is, could be some benefits to doing that rather than putting everyone in these massive risk pools that don't seem to drive the cost down for anyone. So yeah, I want to get your thoughts
Yeah.
there.
I mean, I think number one, patients are increasingly savvy. They have more and more tools to kind of choose doctors that really are align with what they need and what they're looking for. And I think you always want to make sure that you maintain access as well. So you don't want certain populations to get left out in the cold. There's talk in my world on what I do. Well, should we set up centers that are just specialists in treating orthopedic total joint infections, because that takes a lot of resources. If you don't do a lot of it, maybe aren't as good at clearing these infections. Problem is, nobody necessarily wants to be in one of these centers where all they're doing all day long is treating other people's infections, and the finances of that, and the stress of that, and the work that goes into that. You don't want to burn people out. So I think you just have to make sure that there's not cherry picking and lemon dropping going on, and if people are doing the hard work and they're really subspecialized in something that's more challenging, or taking on some of these more complicated things, that you're giving them the resources and rewarding them for that work instead of sort of punishing them for doing that work. And that's going back to some of these value-based care things and BPCI is, I tried, if I thought I could help somebody with an operation and they were safe enough for surgery to do that surgery, there might be some people that say, you know what, this situation, yeah, this person could benefit from the surgery, and yeah, they're as healthy as they're going to get, but they're still pretty unhealthy. And therefore, I say, look, I can't help you, or you're too risky. And then that patient ends up, somebody else says that, they end up in my office, or I end up sending them to the Mecca down in Boston, which is patients, it's hard for them to travel. They might have the resource to get there, and then they have to come back to the community to recover. So I think we have to just make sure we're maintaining access and not run into these issues of, hey, I don't want to be the guy taking care of the complicated stuff, or the person taking care of the complicated stuff.
Can't keep kicking the can down the road.
Yeah, or just, say not it. It's not me. That's not my subspecialization. I only do the straightforward stuff. So you need to go to this person across the street who, takes on all the complicated cases. Now, again, I think it's a balancing act, because, you're good at stuff that you do a lot of. And if you don't do a lot of the complicated stuff, maybe you shouldn't be doing it. But, not everybody wants to do complicated stuff all the time.
Makes sense. Well, this has been awesome. I'm going to ask you one final question, and then we could wrap up. What does the future of healthcare look like to you? Like, what would you see as the top one or two things that push the needle forward and help us achieve that quadruple aim?
Yeah, I think we really have to figure out a way. I mean, things in the front lines are I think, getting a little bit better, but I think there is still a lot of burnout. There's a lot of stress. I think depending on where you go, morale can still be an issue on the front lines, because I think people are feeling, the strain of, having to do more. Patients are more complicated. The resources are less. A lot of people have left the field. And so I think that that's a problem, but I also think it creates an opportunity of who's going to step into that void, who's going to take ownership of it, who's really going to try to fix these problems instead of just kind of ignoring them and continuing to do the status quo. So that's really, what I'm looking at. And I think it's exciting. Things like Mishi and other companies and people that are out there that really are trying to deliver solutions for real problems, because we need them. I mean, we need people to stay on the front lines. We need better ways to treat patients, have access, but address the fact that, in some ways our system is really, getting crushed under the load of what's been going on the front lines. And we need people to take note of that and really deliver real solutions, and people in positions of power to support that and acknowledge it.
Amen. Yeah, and look, it's a lot easier with the support of innovators on the clinical side, such as yourself and other guests that I have had on and will have on. Yeah, we can't, there is no system without you guys. And so I always say that patients are the lifeblood of our healthcare system, and doctors, clinicians are the vital organs. And, us innovators and entrepreneurs, we're just here to kind of support. And so, happy to do so.
Yeah, appreciate that. And I appreciate, honest, earnest approaches, and your co-founders is a doc. So I think it's important to, if you don't have, co-founders as docs, at least involve them. And I'm a big proponent for show up, spend a day in a clinic with somebody, spend a day shadowing, somebody in a hospital, and just kind of see how things happen, because sometimes you might be surprised it happens different than you think that it happens, or something you thought was one way is actually a different way. And I don't think there's any substitute for kind of just real world experience, or at least observation.
Amen. Sorry, I know we were getting ready to end, but I want to double click on that for a second here. From my perspective, have found that has been a big differentiator for me, is having been involved in day-to-day practice operations for such a long time. Gives me a different perspective, allows me to relate to you all and relate to the system as a whole better. I would encourage and implore innovators, entrepreneurs, founders in the digital health tech, med device space. If you're in healthcare and you haven't spent a day doing rounds with a provider, with the surgeon, with the clinician, with the physician, you haven't seen what it's like to route patients from the front office to the back office, to the mid office, to the exam room, get a sense for what the different roles are, and in ClinOps is what is starting to be referred to now. But if that is foreign to you, then maybe either consider doing something else, or take the time to put yourself in that position. Because I think that the clinicians that are wanting for innovation, wanting for resources, wanting for change, are open to sharing their experiences with you. It's just a matter of you taking that step and intentionally exposing yourself to it. Because from what I've seen, there's a massive disconnect between the digital health world and the builders that are operating within it, and the real healthcare delivery space. And so I would love, working to bridge that gap. I'd love to see more people doing the same.
Yeah, no, I've heard the same thing. I've said on a few occasions I have an open invitation if anybody wants to come shadow me, in the Boston area or whatever, to let me know. But I've heard the same thing, particularly at these big conferences and stuff like that you walk around. And if you have experience in healthcare, you kind of get the sense, and I've not been to one of these, but I've heard from people that you get the sense that there's just a disconnect. And I think we're not going to, accomplish what we want to accomplish unless we can sort of address that disconnect.
Yeah, disconnect at the conferences, in the communities. There is, it's clear. Like I'm part of a few different digital health communities here in New York and in New York City, and there's a stark contrast between the digital health communities that I'm in and the actual care delivery communities that I'm part of. And I want to again see a convergence of those two, and we'll do what I can to initiate that. But Ben, Dr. Schwartz, thank you so much for joining us. This has been awesome. Any parting words? And where can people find your podcast? I know you mentioned it. Podcast, your Substack. You mentioned it earlier. You want to give that a shout out again?
Go to my LinkedIn page. Search for Benjamin Schwartz, MD. And then on my LinkedIn page, there's a link to the blog, which is probably the easiest way to find it, or go to Substack and look for Dem Dry Bones. Feel free to reach out to me anytime through any channel.
Dem Dry Bones. And if you need orthopedic care, needed total joint replacement, you know where to look. He's in the greater Boston area.
That's right, North Shore, Massachusetts.
There you go. And I'll link. I'll provide a link to your services that will be available up on our platform and through our networks for people to see and interact with. And again, Dr. Schwartz, thanks so much for joining. It's been a pleasure. And thanks for helping us fix healthcare. That wraps up today's episode of Off the Rails. Remember, you can find us on Spotify, Apple Music, YouTube, and other major podcast channels. Don't forget to subscribe to catch all the content. If you like what you hear, please leave us a review and share it with your friends. Your support means a lot and helps us deliver more authentic takes from real change makers. Follow us on Instagram at GoOffTheRails and follow me on Twitter at Sydney Haytoff. Thanks again for listening. Stay genuine and stay true.